We have lots of guests, so please be respectful and greet our guests. Would you guys stand up and say good morning?
Test.
Well, the problem is that we have all three classes together and no one knows who to lead, so I think that's our problem. Okay, so Troy is our next speaker. For some reason today, I keep thinking about when I taught this grade with these same kids in 8th grade. And it was interesting. In the 8th grade, we were in the middle of COVID. It was our first year, the only year maybe, that we were entirely online. Mm-hmm. And so, for some reason, Troy's camera was always in the dark, and so I could barely see him. I called him Troy in the dark, and I remember wondering, when we all came back to school, I wonder what Troy looks like. That's what I remember thinking. Anyway, I've enjoyed teaching Troy. Even in the dark, he had good insights on the literature we were reading at the time, and he does to this day. So Troy says, these are his words, "I would like to thank Mr. Wade for dealing with my antics of submitting my thesis as late as possible. I would also like to thank my friends who also didn't finish their thesis on time." This kind of gives permission to turn it in late, maybe. "Lastly, I thank my parents for birthing me."
Okay.
Troy's title is "How to Lose a Guy in 10 Days. Please Don't. Banning Gender-Affirming Care for Minors." Give me just a second, and I'll tell you when you can start.
Okay.
All right, you can start whenever you're ready.
Imagine this. You are at the edge of a pivotal moment where your choice defines your future. But then you find out that the path you picked has only led to deep unhappiness. This chilling truth hits some who choose treatments to affirm their gender, but later are overwhelmed with regret. A regret that not only just affects their thoughts, but the very body they wanted to change. What was once a hopeful dream of feeling right in their own skin turns into a constant reminder of choices that they can't take back. In this pain, the search for who they are becomes a trap. And what was once a hope of feeling free turns into a lifelong burden of what-ifs and if-onlys. The earliest recorded trans individual was a Roman emperor called Elagabalus, who wore feminine clothing and even, according to one account, requested surgery so he could create an artificial vagina. While homosexuality was not unusual amongst the Roman elite circles, the desire to change gender was not of the norm. Fast forward in the 19th century, Albert Cashier, a born woman who fought in the American Civil War as a man, was later forced to wear women's clothing after hospitalization. Trans people had lacked access to gender-affirming care up until the 20th century. The first ever recorded sex reassignment surgery took place in Berlin in 1931. In 1952, Christine Jorgensen, a former member of the US Army, made headlines as an ex-GI becomes blonde beauty. This brought attention to a whole new realm of possibilities for transgender people. And in 1966, the Johns Hopkins Gender Identity Clinic was open, a first-of-its-kind clinic on gender transitioning. Moving forward, in 1979, the third edition of the Diagnostic and Statistical Manual for Mental Disorders categorized gender identity disorder as a mental illness. Over time, this view evolved, and by 2018, the WHO had removed transsexualism from its list of mental disorders. Gender-affirming care includes puberty blockers and surgical procedures designed to align one's physical characteristics with their gender identity. With the rise in trans-identifying youth, demand for such procedures has also increased. Though estimates vary, the general trend shows a growing number of transgender identifying individuals. Gender ideology has become a prominent social and medical discussion point. Its impact today is more visible than ever. The process of gender-affirming care consists of three essential phases. First is the prepubertal stage, second is the pubertal stage, and third is the postpubertal stage. In the prepubertal stage, doctors refrain from medical interventions while patients undergo social transitions through name changes, pronoun adjustments, clothing modifications, and hairstyle changes. The pubertal stage requires medical treatment through puberty blockers, which halt the natural development of breast growth and facial hair. The medical community debates the long-term consequences of these reversible treatments, which particularly regarding their impact on bone health. The introduction of cross-sex hormones enables individuals to develop secondary sex characteristics which match their gender identity. For example, a biological male will start growing breasts, and a biological female will start growing facial hair. The postpubertal stage requires surgical procedures including mastectomies, phalloplasties, or vaginoplasties, which result in permanent anatomical changes. The applications of these stages to minors creates ethical problems. Ethical questions surrounding these procedures are grounded in the four pillars of medical ethics: beneficence, non-maleficence, autonomy of the patient involved, and justice. Beneficence is the obligation of a healthcare provider to act in the best interest or benefit of a patient. Non-maleficence is the obligation of a healthcare provider to do no harm. For example, choosing not to resuscitate someone if it means potential side effects that may harm the patient in the long run. Autonomy is limited in minors. Parental consent is required, but adolescents may still participate in discussions. Justice requires fair treatment for all, regardless of gender identity. Yet the real question remains: what treatments are appropriate and safe for everyone? As youth-identifying individuals quintupled from 0.59% in 2014 to 3.08% in 2023, marking a 422% increase in less than a decade, this issue becomes urgent. Without proper policies, children risk undergoing unsafe and irreversible procedures. Therefore, gender-affirming care for minors should be banned for three reasons: the health risks associated with gender-affirming care, the problem of detransitioning, and the belief that minors are not yet mature enough to make such significant medical decisions. Gender-affirming procedures, particularly puberty blockers and cross-sex hormones, pose significant health risks with long-term consequences. One of the most pressing concerns is fertility. Children undergoing transitioning procedures currently have no reliable fertility preservation options, which means they may be giving up their ability to have biological children later on in life. There's also the uncertainty about whether detransitioning could restore fertility, as no viable options or conclusive research exists to guarantee this. Hormonal treatments during puberty can disrupt cognitive and neurological development. Puberty is essential for brain development, and blocking puberty can result in IQ declines of 7 to 15 points, impairing memory as well as cognitive functions. Puberty blockers also prevent bone density increases, which typically range from 8% to 12% in adolescents. Without these, individuals are at a heightened risk for osteoporosis later in life, leading to a higher likelihood of fractures and disability. Short-term side effects of puberty blockers, such as headaches, weight gains, and mood swings, also present challenges. These effects, similar to those of sleep deprivation, can significantly disrupt a child's daily functioning. The very treatments designed to improve mental health may in fact exacerbate psychiatric conditions. For example, the FDA requires warnings for GnRH agonists used in puberty blocker therapy, noting that these treatments may cause mood swings and emotional liability. Thus, the potential risks of such procedures should be carefully considered in any treatment plan. Finally, while proponents claim puberty blockers are fully reversible, there is no definitive evidence to support this. Comparing their use for gender-affirming care to treatments for conditions like prostate cancer is misleading and unsupported by science. Without proper long-term data, the assumption that puberty blockers are entirely safe or reversible contradicts core medical principles, especially non-maleficence, which emphasizes doing no harm. Misinformation or oversimplification in medical practice can lead to irreversible damage and deteriorated quality of life. It has no place in medicine. Moving on to the next argument, detransitioning, whether social, medical, surgical, or legal, represents a serious issue for minors who rush into gender-affirming treatments without fully understanding their gender identity. Many adolescents pursue these treatments impulsively due to social pressures or underlying mental health struggles. However, for those who later regret transitioning, the process of detransitioning is not simple and is often hindered by irreversible changes. Hormonal therapy, for example, can lead to permanent physical changes, including breast tissue development, voice changes, and irreversible alterations in reproductive functions. These alterations cannot be undone, and individuals who regret transitioning may find themselves dealing with new insecurities and deformities. A case in point is a girl from England who, after undergoing a medical transition, questioned her decision after complications from a botched surgery. Despite transitioning physically to resemble a male, she realized that society would recognize her as someone who had transitioned. She regretted her decision, acknowledging that had she received counseling earlier on in her life, she might not have chosen to transition at all. The societal acceptance for gender transitions is another challenge. While gender is often viewed as a social construct, not everyone accepts this view, with many still holding that gender is determined by biological sex. Approximately 60% of adults in America reject gender ideology, and societal stigma, including harassment and familial pressure, contributes significantly to the detransitioning process. These external pressures make it difficult for individuals to live openly as transgender, further complicating their mental health and sense of self. Even after undergoing gender-affirming medical treatments, the intended improvements in mental health are not guaranteed. Numerous studies evaluating the mental health effects of puberty blockers have shown improvements in mental health, but these studies fail to isolate the effects of treatments from concurrent psychotherapy. In fact, many transitioners still require ongoing mental health support, indicating that medical transition alone may not address the underlying psychological issues. Furthermore, some studies indicate that trans individuals also continue to have mental health challenges post-transition. A study of 963 trans youth indicated that hormone therapy resulted in an increased rate of psychotropic medication use, but did not significantly reduce mental health concerns. This also suggests that gender-affirming treatments alone do not necessarily address the underlying problems pertaining to these children, and that we cannot simply treat their mental health needs holistically. The irreversible nature of medical transitions and the lack of conclusive evidence around the mental health benefits of medical treatments, as well as the heightened possibility for regret, raises a serious question of whether medical transition is in the best interest of minors. For my last argument, the principle of autonomy, which is a key principle of ethical decision-making in medicine, represents the ability to make informed and independent decisions. For minors, autonomy is complicated. Minors are still developing cognitively, emotionally, and socially, and as such are considered more vulnerable and unable to make fully informed decisions, as they may lack the understanding of potential long-term impacts. Their brains, particularly in areas responsible for risk assessment and decision-making, are not fully developed until their mid-20s, increasing susceptibility to peer pressure and impulsivity. Because of this developmental immaturity, minors are more likely to engage in risky behaviors and be influenced by external factors like social media, peer pressure, or family dynamics. This becomes especially concerning in medical contexts. For example, a minor may seek a permanent treatment such as cosmetic surgery or gender-affirming care without understanding the risks or ramifications of treatments in the long run. Beneficence, the ethical principle that obliges one to act in the best interest of others, encourages limiting autonomy for minors in order to minimize harm and maximize well-being over time. This expectation does not provide for absolute no autonomy. There should be consideration for minors' choices, but they should be guided by mentally capable human beings with age-appropriate education, involvement of their parents, and careful assessment and planning. In addition to beneficence, other ethical principles would support limiting high-risk decisions until maturity and informed choice have been reached. One could include non-maleficence or doing no harm, since gender-diverse youth face some of the greatest mental health challenges within a societal context that normalizes injustices towards vulnerable groups. In the specific area of gender identity, the priority will be to provide access to psychological support. It is well established that mental health challenges within the gender-diverse youth population nearly always stem from social rejection or family issues rather than being related to gender dysphoria per se. Access to therapy could provide a safer, reversible opportunity for minors to explore their identity so that they can start to mature psychologically and emotionally and then decide on how to proceed if appropriate and at an appropriate time. Given that many youth will not identify in the future, there is risk in exposing them to irreversible treatments sooner than it is appropriate. Ultimately, there is a chance that they will do more harm than good by rushing through a permanent reporting of their identity. A notable example is a 17-year-old biological female who socially transitioned into a male at age 14. After undergoing years of therapy and hormone treatment, decided to delay chest surgery. Upon further reflection, the individual realized they were not male, but non-binary. The decision to wait ultimately led to a clear understanding of their identity. This case highlights the importance of waiting and giving minors space to come to terms with their gender identity. Protecting the young from irreversible decisions is not the denial of their identity, but the preservation of their future. Although some might argue that gender dysphoria can become so severe to the point where mental well-being is concerningly affected, they believe that the severity of some individuals' conditions would necessitate medicalized treatments, and banning them would lead to increased distress, even death. While it is true that mental well-being will be affected, distress is the main thing that needs to be dealt with. As for actual severity, there is a lack of solid evidence that distress can be mitigated through medical treatments. Sources and studies that say so do not distinguish between the effects of actual medicalized treatments and the effects of psychotherapy. Therefore, because of the lack of evidence that medicalized treatment does in fact help mitigate distress, the risks end up outweighing the benefits. Especially for minors who are vulnerable and cannot afford to inhibit their development, if something can be treated through therapy and actual mental care without anything involving the administration of hormones and other treatments, we should always choose that option. There remains the argument that cognitive maturity tends to be overemphasized, and that minors can be trusted to make informed decisions without overprotective parents holding the reins. They cite research that suggests adolescents can make rational choices when appropriately guided and supported. This would mean that we should be about enabling minors, and not preventing them from making dangerous and wrong decisions. However, youths are vulnerable to external influences of social media, their peers, and trends which can help heavily inform their self-perception and their identity choices. Teenagers are particularly subject to affect biased and distortions in their judgment. This is particularly telling when based on often emotionally high-stakes decisions where medical transition is undertaken. While aspiring to autonomy is vital, it is critical that it be exercised within a protective framework that recognizes their developmental vulnerability and without structural protections, decision-making motives may arise from and for the wrong reasons. This thesis has demonstrated the serious risks and mental effects surrounding gender-affirming procedures in minor patients. These procedures can cause irreversible changes, and minors may not have the maturity to scientifically assess or fully anticipate long-term outcomes. Of course, an adult may want to affirm a young person's identity, which can generally be selfless in its intent. But the four principles of ethics should compel each of us to be mindful that safety, caution, and potential long-term welfare comes before affirmation just for the sake of affirmation. Even after medical intervention, underlying mental health struggles often persist, showing that physical changes alone are not a cure. At the heart of this debate is not just policy or science, it's ethics. It's about how we protect our children who embody hope, innocence, and future potential. To ask them to make life-altering choices too soon is to risk dimming that light before it fully shines. To ban gender-affirming procedures for minors is not to deny these realities, but to honor them, out of deep respect for the complexity of human identity, the sanctity of childhood, and the wisdom of time. It is a pledge to protect the right of every child to grow, to wonder, to experience, and to become the person he or she will ultimately be without the burden of lifelong consequences they may one day come to regret. In a world so eager to provide solutions to sensitive and complex problems, perhaps the greater act of compassion is not in saying yes too quickly, but in the courage to say wait, so that time, reflection, and maturity can do what permanence can never undo. Thank you.
Thank you, Troy. Our panelists are Miss Viola and Miss Bethany. Miss Bethany, would you like to go first?
Hello? Okay. Very good job. Very well spoken, and I thought your argument was very balanced. With a lot of research, you've clearly researched quite a bit, and it shows. So my first question, based on some of your research, has a little bit to do with what you said about autonomy. You mentioned that kids are not fully capable, not cognitively capable of making such an extreme decision like this. You also point out that the brain is, scientifically, we know that the brain does not finish developing until the mid-20s. You also give an example of a girl who began her medical transition, but then sort of backpedaled and tried to detransition, I believe. She was 18 years old at the time?
17. Yeah.
17, okay. So with all of those things in mind, what is the age that people can reasonably make this decision?
Thank you for the question. Well, I categorize minors in my thesis as people who are below the age of 18. After the age of 18, well, I'll put it like this. So law enables us to have certain rights and things we can do after the age of 18. With those rights and that power, well, it comes with responsibility and as well as accountability as for adults, right? So after the age of 18, well, of course, we can always encourage these people who want to transition to maybe backpedal a bit, maybe rethink their decisions, but ultimately, the decision ends up being in their hands, right? So yeah, that would be an answer, yes.
Okay. My next question refers to the levels that you talked about of the gender-affirming care. So the first one being the social aspect, and then the second one, the hormone, and then the third, the medical, surgical side. My question to you is there a case for allowing that first tier, to allow children to sort of go into that gender-affirming care that is not medical, is reversible, it's not permanent? In other words, is it acceptable to allow children to transition socially?
Thank you for the question. Well, although the social transition might be reversible and it doesn't necessarily have any physical changes to your appearance and body, I don't think it's still it's acceptable because you're still letting your child explore these ideologies which may later they may later end up, pursuing these treatments and surgeries in the future, right? So I think it's still a dangerous part of the gender-affirming care in itself, even though it has no physical alterations happening to your body.
As a person who does want my own children in the future and wants to be a good parent, and I want to parent with a biblical worldview as well, what is a biblical approach to parenting a child that may have gender dysphoria or may explore these kinds of ideas?
So I have prepared a Bible verse for this. Thank you for the question. It comes from, I believe it's Matthew 18, verse 6, or Matthew 18, verse 10, if I'm not mistaken. But whoever causes one of these little ones who believe in me to sin, it will be better for them to have a large millstone hung around their neck and to be drowned in the depths of the sea. Well, this clearly shows that parents, we have to guide our children towards the right path, right? And you want to raise children, of course, right? And for your children itself, when they're still within your parental protection, you can always, do your best and try your best to maybe encourage this child to rethink their decisions and to, evaluate everything that might happen to his body, the potential side effects, and make sure he or she is informed of their decision, right? But there comes a time where after you release him from your home, it goes to college, it goes into work life, after the age of 18, of course. I'll give an example for this. So let's say you have a friend who takes drugs. We clearly know it's wrong. It's very harmful to his body. I think he or she definitely knows it's harmful to their bodies. And we've tried everything we can to encourage, to stop him from trying to take these drugs again. Because it's dangerous for him, right? We always want what's best for him or her. But if he ends up doing it, then are we liable for the sin he did to his own body? So I think there comes a point, especially with gender-affirming care as well, that your child will have to make his own decisions and be accountable for his own actions. So yeah, that'll be my answer, yeah.
Very good. That's all I have. Ms. Viola?
Hi, Troy.
Hello.
First of all, reading your paper, I will appreciate you. I really love the angles that you choose to have the ethical consideration included in this analysis. That's a very well job. And then you have sufficient theoretical understanding about this issue, and also, as I read this, you have anticipative towards other perspective of challenges, like I want to refute, you have another explanation already. So that's really nice that you find the counterproductive in other sides' argument. So very well done for your thesis, which I just knew from Mr. Wade that ternyata ada sisi late submission ya. But I cannot see it when I read your paper, so good job for that. However, my question is that, so you've talked about gender dysphoria, you've talked about how these youth are struggling, and then the gender identity and so on. But first of all, I would like to hear from you first. So, what the underlying issues of this topic is about the gender identity, isn't it?
Yes.
So, what defines gender? What makes a man, and what makes woman a woman?
Well, there's two definitions of this, right? First is gender defined by sex, which is biological and what you're born with. And then there's another concept of gender, which is more social, where it's more flexible and it's defined as what you think you are as a person, of course.
So which definition that you choose as a definition of gender?
I did both perspectives in my thesis, yes. But in my opinion, my personal opinion, I view gender as biological sex.
Okay, biological sex. Okay, now, my next question is, have you ever known that there will be a case where when the baby is born, it's unclear for us to judge whether this baby is a girl or a boy because of maybe some of the biological issue? Let's say there is a case of, have you ever heard the hypospadia case?
I don't think so, no.
Oh, okay. So in Indonesia lately, there was a case when there's an athlete, she or he, she is experiencing a hypospadia where she was she was born and then judged by the doctor as a male because of the urethral condition, and then she was raised. Oh, she was born, and then because of the unclear, ambiguous characteristic, so she is judged as a girl, raised as a girl, and then developing as an athlete, and then playing in the tournament for the girls. So when she become adult, she deeply knows she experienced a gender dysphoria in childhood, right? But no one heard this. No one knows about that. So there's the time when she finally fight for her gender dysphoria, claiming that she is a male, and then later on, the assessment is being done. So how about this case? At this time, it was kind of late for her to have the gender-affirming care. So she has developed already as a cross-gender. So wouldn't it be better for her to be allowed to have gender-affirming care when she was minor back then?
Sorry, to clarify, was she wrongly identified at birth?
Because of the hypospadia condition.
Which is
Which is the
Sorry.
it's the physical condition where it is unclear which your urethra position. It's not, and sorry to say, it's not in the penis, but it was way closer to the body, so it could be misjudged as the vagina as well.
Okay, so sorry, can you repeat your question before?
Okay, the question is, wouldn't it be better for her to be given a gender-affirming care when she was minor, before it was too late?
Okay, so thank you for the question. Well, as I've mentioned a lot in my thesis before, there are a lot of health risks and dangers that are associated when you go through these gender-affirming procedures as a minor, because of course your body is still developing, having major development, and that major development only stops round about when you're 18 or 19, right? So I think it's very, very risky, even if she were to, let's say, find out about her gender before the age of 18, I would suggest still waiting until you're 18 to pursue these treatments.
So you are going to say wait,
I
like
say
what
wait.
you say, the courage to say wait.
Courage to say wait.
Okay, so what do you think? So if that was the case, what do you think is the main struggles of this TGNC, the transgender and non-conforming people? Is it following, because you said that even if you have gone through the physical intervention, the mental health risk was still there, so it's not enough, right? So I wonder whether which one is more distressing for them actually, which one is stronger? The mental distress following the transition, or the mental distress before the transition?
Thank you for the question. Although I did not research particularly on this part, I would say, well, it's a different distress for both, right? First, the distress that comes before your transition, well, you don't feel like you're in your own body. You felt like you're the other gender, and well, right now, of course, if you're a male, you want to transition into a female, and you feel like a female, well, of course, you don't look like a female, right? So that's part of the distress before transition. But after transition, what if you don't look like how you want? Your physical appearance will not necessarily be perfect as a transgender because, well, of course, treatments are imperfect, as well as our technology hasn't developed that far yet, and you're doing something that is not natural to your body, of course. And it's like, let's say, cosmetic surgery. Maybe you get a nose job. It won't necessarily turn out as perfect as how you want it to be sometimes, right? So maybe the stress comes from there as well. And or maybe another part of it after transition is that, oh, maybe I don't feel like a female anymore. Maybe I felt like a male in the beginning, at first, So I guess the distress after transition comes from regret. Yeah, most likely from regret, yes.
Okay, so while the distress before the transition is the dissatisfaction.
Dissatisfaction.
So you are saying that let's bear the dissatisfaction
yeah.
rather than you bear the regret.
Yep.
Okay, thank you. So you are saying that these minors are very young to make a decision over their own. So I like the ethical perspective that you choose. That therefore they need the parental consent, right? And that's also what usually happen in our
Yes.
medical decision. The question is, what if their parents are, when they came out, just like what Miss Bethany is saying before, when they came out, their parents are the one who affirm them and then give the parental consent. Would it be still ethical for them to do gender-affirming care?
No, absolutely not. I think. Thank you for the question. I think if the parents are also part of this ideological craze and they they encourage their child to pursue these treatments, knowing the risks, knowing the dangers associated with it, well, I think they should be held liable for child abuse. Yeah.
So you are saying that these parents should be put the stone
Yep.
and then throw the
Yeah, that one, yes.
Oh, so this kind of parents yang harus dituin ya. Okay, thank you for that one. So talking about that, you know that we are living in a society where here we are having this statement of I have all the right to choose who I am, right? So I am the one who define who I am. So here we are in this kind of society where they say, I choose. It's my human right to decide. I can choose what I want, and especially in the psychological. Coming from a psychological perspective, even APA, the American Psychological Association, when they are publishing their guidelines for handling the transgender, let me read it for you. The APA even say that psychologists should understand that gender is a non-binary construct that allows for a range of gender identities and that a person's gender identity may not align with sex assigned at birth. So here we are. So it's not only the ideology made by some people and then fight by some people, but also the professional who also fight for their justice. So what do you think about this one? We are battling against this kind of society and that kind of political influences. What do you think about that?
Can you clarify your question?
Okay. So my question is, here you are standing as a grade 12 student talking to us. Let's not affirm this gender-affirming care for minors, especially because of loss of the risk that will go on. However, outside of this room, we are facing a community which will fight for this ideology, freedom of choosing, and even the political influences that would give them justice and cover that that psychologists also have to see them as a non-binary construct. So what do you think? What's your opinion about this, and what do you think that we need to fight for? Because they would say this is the justice, and justice is the fourth ethical perspective that you brought in your paper, right?
Thank you for the question. Well, here, of course, we have a Christian worldview and a Christian perspective towards gender, identity, and sex itself. Well, we believe that gender is defined by biological sex, of course. But outside of this Christian worldview, then, as you said, maybe it's a bit more liberal where they bring in that gender is non-binary and we cannot necessarily bound it to any physical thing. If I were to answer, well, if we had lived in an idealistic world where Christianity is the main rules of the Bible is the main rule book for everything that we do, well then, by all means, we should definitely fight for gender being just sex. Well, if you're born like this, you get this, and it's no discussion. But we do not live in an idealistic world. And I think you mentioned America, right? I don't think America runs their laws based on the Bible, no, right? So, yeah, it's a bit more liberal. Yeah, a bit more liberal. Well, if it's Indonesia, well, it's different. We base our laws on, well, not all of it, but we're an Islamic country, right? So here it's not really, they don't lean towards this non-binary gender ideas. So I guess it's a bit hard to answer one specific answer for this, but personally, I would definitely try to fight for my own definition of gender, right, as biological sex. But right now, as the world transitions into a more free, liberal, open world, it gets harder and harder to control these definitions. Yeah.
Okay, so I have a couple of questions. Thank you, Ms. Viola. So I'll extend a little bit what you were just talking about. So you've done a great defense for a secular audience on why this should not be banned. Now, how about the Christian audience? If you look at identity, comment on identity from a Christian worldview. Aside
Sorry?
from, so how do we find our identity as believers? Is it in how we define our sex? Identity in general. I'm not talking about sexual identity. Identity, where does it come from, and how can you comment on that from a biblical worldview?
Do you mean identity like sense of self, or? Oh, thank you for the question. Well, in my opinion, most of our ideas and thoughts and ideology from Christianity stems from the Bible, right? Finding your sense of self, well, there's no clear-cut way on doing that, right? One day maybe it comes to you, maybe God gives you a vision or a dream in a prayer, or you find out in a prayer, like a little eureka moment where your identity shows itself, right? So I guess that would be my answer, yeah.
And what do you think about the scriptures in the Old Testament that talk about how we were all made exactly the way God intends us to be? And we're made, first of all, in His image, and second of all, we're stitched according to His plan, not an accident. So how does that impact your thesis?
Well, of course, and as mentioned before, in a Christian worldview, this is definitely not okay, even for adults, right? So not only minors, but it even goes further for adults. Of course, clearly, if we're based on the Bible, it's clearly sin to want to change your gender, right? Because you're stitched according to the image of God. Well, that is definitely not okay for even adults to change their gender. But again, we do not live in a Christian world right now, right? We do not live in that idealistic world where we can have these rules and we can have these Christian ideologies spread for everyone, because everyone has their own ideologies. So I guess it becomes difficult to push these ideas, yeah.
One more question, and that is about Indonesia. It's like, surely, this is a big issue in the West and in the developed countries. How about Indonesia? Is this really an issue that people have here? Are there really medical procedures happening here? Is there really gender-affirming care for minors here in Indonesia?
I don't think so. I don't think there is gender-affirming care here in Indonesia. I don't think it's spread that far yet to the east. As for gender ideology itself in Indonesia, I think the perception of it is definitely still a lot of stigma on them, right? Like just the LGBT community in general. I think most people in Indonesia are disgusted by it, and hopefully there's no switch in mentality, but if we look at the general trend of the world right now, I think everybody's becoming more accepting to it, right?
Yeah. So this is something we may face.
This is something we may face in the future, yes.
All right, thank you, Troy. Your time is up. Good job. Oh, yeah. One thing that's interesting, and we didn't bring this up, but because of the very things you brought up in your thesis, that kind of research, England is actually starting to has made it illegal to do some of these things in England, which is a very progressive place, right? So yeah, your research is definitely relevant and other countries are actually seeing it as well. Okay, what we'll do now, friends and family and advisor, meet over here for photos, and then we will start at in about 5 minutes with Eben.